All right, so this is the MEC Minute you've been waiting for. It's the 2026 protocol update. And what I hope to do is go over some of the high points of the protocol revisions for next year. So we're going to review the changes to the protocol that are effective January 1st. We are going to pay particular attention to how we incorporated the American Heart Association BCLS and ACLS guidelines. I'd like to remind you that last month I reviewed these guidelines and discussed which ones we're going to incorporate into next year's protocol. So if you really want more detail about the American Heart Association guidelines, please go back to last month's MEC Minute. I also want to spend some time talking about joint treatment guidelines released by American College of Obstetrics and Gynecology in conjunction with the National Association of EMS Physicians. These guidelines had to do with obstetrical emergencies, principally eclampsia, hypertension, and postpartum vaginal bleeding. And I'll spend some time on that. We are adding a couple of medications to the protocol because of these guidelines, which I think are substantial changes and an improvement to the care that we can provide our patients. Just some general comments. The protocol is effective January 1st at first thing at 1 minute after midnight. And then on the January 1st, please update your ResponseSoft app. Sometimes when you open up the app, it'll prompt you to update your app. If you don't see a prompt, please check the date at the top of the first page. It should have the first of the year on it. If not, you may have to delete the application, or delete the protocol and reinstall it with the same protocol number. If you have any questions or concerns or suggested edits to me, please or questions, send them to me at this email address. I'll get back with you. It'd be good if you have some suggested edits or comments to check with your other providers at your station to see if they have any suggestions as well, so that I get as many good comments as possible in the fewest number of emails. And then as part of our competency assessment every year, we do protocol assessment, which is, for lack of a better term, a written test. It'll be distributed by the first of the year, and you have a month and a half to get it done. As in previous years, the protocol assessment is a learning tool. You pass by taking it, you fail by not. I encourage everybody to do it as joint activity with your partners on duty. I think that's the best way to look at this and learn. I will also distribute a MEC Minute review of the protocol assessment where I explain the rationale behind the questions and the answers. So just a couple of formatting things or things to take a look at. We have the index of or table of contents on the left-hand side of the ResponseSoft application. And then I'd like to point out that if you click under reference on the left side, you'll see a tab for protocol changes. If you go to that tab, it'll take you right to the protocol changes as listed. And you can click hyperlinks to take you directly to the protocol changes or the protocol that has been amended. And then we have added something, and it's at the bottom of the column on the right side. We've added some special protocols. So in the past, we've had some pilot programs such as sepsis and other things where we had special protocols, and we put them out as a separate document. We started now to incorporate them into the main protocol. And currently we have three that are out there. One is the opioid withdrawal protocol that is being piloted at Lancaster. It involves assessing patients in withdrawal and providing Suboxone or buprenorphine. We have the Cavalier study coming up, which has to do with pre-hospital calcium use in trauma patients. Westlicking, Violet, Mifflin, and Truro are participating in the study, so we'd like to see what comes of that. And the protocol is in the ResponseSoft app now. And then we're also doing a trauma jail pilot at Hocking County EMS, Truro, and Mifflin. That protocol is now also part of our MEC EMS protocol. So I just kind of highlighted those two areas for you. Some the updates, American Heart Association updates to the protocol. I reviewed them last month. I would encourage you to go back and look at the MEC Minute again if you have any significant questions. But in terms of our protocol, we have adjusted the ventilation rates for children and infants in our CPR procedure. It was poorly spelled out in the past. I think it's all corrected now. We looked at the foreign body airway obstruction algorithm from American Heart and updated our protocol to include some of the key steps, which have to do with back slaps and so on. We have moved to the NPR algorithm for newborn resuscitation, which I'll show you in a moment. We've also added a comment: if you have a patient that has torsades, our first treatment is to shock the patient. Magnesium sulfate comes second. Previously, we'd give the patients mag sulfate, but American Heart considers torsades to be an unstable rhythm. Therefore, we don't wait for mag sulfate to work. We shock the patient. And then we've adjusted the LVAD guidelines that we have in our procedure section to follow the American Heart Association's algorithm in terms of how do we assess a patient who may be in cardiac arrest or may be suffering a problem related to their LVAD. I'll also review that algorithm in a minute. Some other things we've done with newborns: we added delayed cord clamping, so we put the baby on mom's chest and keep the baby warm and clamp the cord a minute or more after delivery. We are emphasizing IVs over IO, so try for an IV, and if unsuccessful, go for the IO, but at least give the IV a chance. I made the comment last month we are going to keep mechanical CPR. American Heart doesn't recommend it, but we use it because it gives us the ability to free up hands and for our providers to be safely secured in the trucks during transport if the patient requires transport. For patients in cardiac arrest with PEA and asystole, otherwise known as pulsus or cardiac arrest, epinephrine, we've added a comment to give it as soon as possible for non-shockable rhythms. And we are also adding emphasis in our protocols for push dose epinephrine and epinephrine infusions for hypotensive patients. So bottom line regarding epinephrine is if the patient's in pulsus arrest, give it to the patient as soon as possible. That's when it's shown to provide benefit. And go back and take a look at the protocol regarding push dose epinephrine and epinephrine infusions, because there's increased emphasis in the 2026 protocol on use of epinephrine for hypotension and bradycardia. So you should be very comfortable with mixing up epinephrine for infusion and push dose administration. And then we've also made an adjustment in our termination resuscitation time. We've reduced the time now to 20 minutes. We increased it to 30 minutes a couple years ago. Now, based on American Heart guidelines, I've agreed that we're going to reduce it to 20 minutes, which I think is probably to everybody's liking. So no response to good resuscitative efforts, no contraindications to termination, then you may terminate. I mentioned LVAD assessment algorithm. This is the American Heart Association algorithm adjusted to meet our format. And if you have a patient who is not acting right, maybe suffering from hypotension or cardiac arrest, how do you assess them? Well, if the patient has an LVAD in place, they will probably still have flow. So the idea is to evaluate the patient and see if they have adequate perfusion, if the patient is mentating normally, if the patient has normal capillary refill. If the patient has an end tidal CO2 over 20, then they are probably perfusing. It'd be nice to get a pressure on the patient. However, with an LVAD in place, typically you cannot get a blood pressure unless you use a Doppler device and you listen for the pulse. So you can pump up the blood pressure cuff, apply the Doppler device over the brachial artery, reduce the pressure, and when you start hearing noise through the Doppler, that's the patient's mean arterial pressure. It's not diastolic, it's not systolic, it's the mean arterial. And if it's over 50, then the patient is considered to be perfusing adequately. If the patient is not perfusing adequately, then you can think about, is there a reason for fluid loss or blood loss? The patient might benefit from a little fluid administration. Typically, it doesn't take a lot of fluid unless the patient has a source of bleeding, such as GI bleed. All the LVAD patients are anticoagulated, so bleeding is an issue. But if you don't see any obvious bleeding, a small bolus, maybe 250 of saline may help. If the patient is unconscious, that you think they are in arrest, start CPR. Do chest compressions manually. Do not use the Lucas. And standard ACLS and BCLS treatment otherwise should be provided. So that's a quick review of how we would assess a patient with an LVAD who is in trouble. In terms of the updated OBGYN protocols, I mentioned delayed cord clamping earlier. So, deliver the baby, put the baby on the mother's belly or chest, keep the baby warm. Babies are little radiators and lose heat very quickly, so keep them warm. Delay clamping the cord for 60 seconds or more, and you can clamp the cord and move on. In terms of the updated protocols, we have increased our magnesium sulfate dosing to 4 grams IV over 20 minutes. We have also added the option of giving 10 grams IM, but that is a lot of volume. So as I calculate, it's about 20 milliliters of magnesium sulfate, which means you'd have to give the patient 3 or 4 shots. Excuse me. I think preferably we would give the patient mag sulfate IV and give 4 grams. We are adding 2 new medications to the protocol, Nifedipine or Procardia, 10 milligrams orally for hypertension based on the parameters that I'll show you in a bit. Some of you may be old enough like me to remember when we gave Procardia sublingually for hypertension. It did actually too good of a job and patients would become hypotensive. So we will not administer nifedipine sublingually. We will only give it orally to patients who are pregnant and qualified. Excuse me. We've also added oxytocin intramuscularly for postpartum bleeding. Postpartum bleeding can occur up to 12 weeks after delivery. Generally, we see postpartum bleeding within the first week or 2. Postpartum bleeding can be very heavy, can be life-threatening. We're adding oxytocin. Oxytocin helps the uterus to constrict. When the uterus constricts, it cuts off blood flow to the uterus and the bleeding diminishes. The idea is if you think the patient has significant postpartum bleeding, give them a dose of oxytocin as soon as you can intramuscularly. It's only 1 cc of medication, but give it IM, and it should help the patient start to recover. My feeling is oxytocin IM is similar to why we give midazolam IM for seizures. You can give it to them very quickly IM, whereas it takes time to get an IV established. We will not be giving oxytocin intravenously, although it can be given in areas such as labor and delivery. So just a medication review, nifedipine, we use it for OB emergencies, particularly hypertension and pre-eclampsia. It's not indicated in children unless they happen to be a pregnant teenager who's suffering from hypertension or pre-eclampsia. The dose is 10 milligrams. We will not give it to patients who are not pregnant or who are known to be allergic to it. It can cause angioedema, pulmonary edema, nausea, vomiting, headache, dizziness, can cause hypotension. These all are rare, and this medication has been proven to be very safe for pregnant women who are hypertensive. We should monitor their vital signs after administration, and if the patient does develop some hypotension after nifedipine, a small fluid bolus may be indicated. And I forgot to mention, Procardia is a calcium channel blocker, similar to cardizem, and it's used in the community quite commonly for management of hypertension. Oxytocin or Pitocin is for postpartum vaginal bleeding, and we would use it after the baby and the placenta is delivered. So if you have a woman who has just delivered and the placenta has been delivered as well and the patient's bleeding quite heavily, it would be appropriate to give oxytocin. If the patient is recently postpartum and is now at home, you are called because the patient's having heavy vaginal bleeding and it's within 12 weeks of delivery and they are hypotensive, look bad, or seem to be just bleeding out, then give them oxytocin, which is 10 units IM. Again, there's no pediatric indication for this unless we're treating a postpartum teenager. We will not use it in any patient who's in active labor or any patient who's got uncomplicated pregnancy or any patient who has vaginal bleeding not related to recent pregnancy. It can cause hypertension, nausea, and vomiting. Some people are allergic to it, but it's rare. Rarely causes seizure or cardiac arrhythmias. Probably nausea and hypertension are the most common reactions, but the patients tolerate them well. If the patient does become hypertensive, we do not treat them with nifedipine. patients generally will do much better with oxytocin than without. Our goal is to slow the bleeding down and to resuscitate the patient. And it's the use of oxytocin has been well established for controlling postpartum hemorrhage. It may also be used in labor and delivery to induce or augment delivery, but that's not why we're using it. We're using it because the patient has postpartum vaginal bleeding and it's heavy. So getting to postpartum hemorrhage, by definition, it's significant vaginal bleeding up to 12 weeks postpartum. That could be 1 hour post-delivery. It could be 10 minutes post-delivery if the placenta is delivered. It could be up to 12 weeks later. You'll have to use some clinical judgment. So if we're talking about a patient who's further out from delivery, let's say 6, 8, 10, 12 weeks, and now she's having some vaginal spotting, maybe she's starting to have a normal menstrual cycle. We would not use this medication for a patient who is just spotting. We want to use it for patients who have significant heavy vaginal bleeding, which has the potential to become life-threatening. You have to make that clinical decision. Could this be potentially life-threatening? If the patient's tachycardic and or hypotensive and or sweaty and looks pale and is in trouble, use the medication. We're going to give it IM, give it early, don't wait to see. The other thing we've added to postpartum hemorrhage is TXA 2 grams IV push. I will talk a little bit more about this later, but we're going to change TXA from 2 grams IV piggyback to 2 grams IV push over a few minutes. So we don't have to worry about infusions anymore. It's put in a syringe and give it over 2 minutes. This is the algorithm I was talking about. Regarding vaginal bleeding. It's really this section in the middle that I want you to pay attention to. So the patient's postpartum, immediately following delivery up to 12 weeks, and they're hypotensive, we're going to give them Pitocin IM. If the patient is just delivered, you can massage the uterus above the symphysis. So you should be able to feel it above the pelvis. You should massage it with a hand or two. Massage helps the uterus constrict, as does oxytocin. When the uterus constricts, it cuts back on the amount of bleeding vaginally. Once you get IV access, we'll give the patient TXA IV over 1 to 2 minutes. So I think this is a big step up for us. We've had a couple really bad postpartum hemorrhages, and I think we're really helping our patients by adding this. For hypertension in pregnancy and pre-eclampsia, we're adding Procardia for blood pressure control. It's safe and effective. It's a calcium channel blocker. It works well. Before adding this, I met with some obstetricians, particularly the oversight group for obstetrics at Mount Carmel East, and they support this. If a patient arrives in labor and delivery who is hypertensive and is an L&D triage, they will give the patient Nifedipine as they start their assessment. So what we're going to do is in line with what they do at the hospital. We will give this medication to patients that are pregnant and hypertensive or who meet criteria to be considered pre-eclamptic. We will not administer to a patient who is eclamptic or having seizures. And the main reason is because if the patient's having a seizure or is postictal when you arrive, really we should not be giving the patient anything orally. Those patients will be treated with mag sulfate. For patients who are hypertensive and preeclamptic, we're going to start them on mag sulfate in addition to Procardia. Again, we've upped the dose from 2 grams to 4 grams over 20 minutes. We can give 10 grams IM. I'm not a big fan of that, but it is an option if you need it. It's a lot of volume, which means 3 or 4 injections for the patient. You need to watch for magnesium toxicity. For us, the biggest side effect of magnesium that can be a problem for us is respiratory depression. So keep an eye on the patient, watch their respirations. The patients will do well if you give them 4 grams over 20 minutes. If you give it to them over 10 minutes, they may develop some respiratory compromise. So give it over 20 minutes IV piggyback. If the patient gets into trouble and they lose respirations, the treatment of mag toxicity is calcium chloride, but I would avoid doing that at this point. Just keep an eye on the patient and make sure you don't infuse the magnesium too fast. So here's the protocol that I mentioned for hypertension, and here we have parameters for treatment. And again, if the patient's blood pressure is 140 to 159 systolic or 90 to 105 diastolic, and have other symptoms such as headache, blurry vision, or belly pain, they would qualify for treatment with nifedipine and mag sulfate. Or if, regardless of how they feel, their systolic is over 159 or the diastolic is over 109, we are going to treat them with nifedipine and mag sulfate. Keep in mind that pregnant women tend to have lower blood pressures during their course of the pregnancy. So if the patient has elevated blood pressures, we worry about eclampsia and pre-eclampsia. If the patient has any signs of mag sulfate toxicity, we will discontinue the infusion and can give calcium chloride as indicated at the bottom left box. If the patient receives mag sulfate, they really need to be monitored with blood pressures every 5 minutes. Put the blood pressure cuff on and keep it running, and make sure that you keep the monitor on until somebody takes the patient off your hands at the hospital, in the emergency department, or preferably labor and delivery. Eclampsia, remember, eclampsia can occur up to 6 weeks postpartum. Eclampsia is seizures associated with pregnancy and hypertension. We use midazolam for the seizures, and we start the mag sulfate early. Think about how you're going to get that into a patient. Again, it's 4 grams IV, piggyback, or 10 milligrams IM. We are going to add another option for IOs. It's going to be the femoral distal femur in adults only. This has been used in San Antonio for more than 5 years without significant complications. So I think it's something that we should consider as another option. It's a new access point for us. It has a success rate that seems to be better than the tibia, and comparable to the humerus. At this time, it's only adults, and we're going to use the yellow needle. The insertion site is in the midline overlying the femur, about 5 centimeters or 2 finger breadths above the top of the patella. So you put the leg in a straight position, you extend the knee fully. You take 2 fingers above the top of the patella in the midline, and that's where you put the needle. There's been some discussion about if they have a lot of fatty tissue in the area, can you take a scalpel, make a little nick in the skin, and put the needle through that? For now, we're just going to stick with the yellow needle, and if we need to talk about making skin incisions, we'll address that at another time. But think about this. We're going to have a training program come out for it. My thanks to Rich Charles and Eden Harden for putting this together. Would love to hear your feedback about it if you use it. Just want to quickly mention those medications that have recently been added for EMTs. EMTs have in the past been allowed to use EpiPens, but now they can draw up 1 to 1,000 epinephrine and administer it intramuscularly for allergic reactions. EMTs can now also administer glucagon intramuscularly. Glucagon can be given nasally. However, it's a different formulation than what we use for intravenous use, and it's extremely expensive. Glucagon is expensive as it is, but the intranasal version is close to $500 a dose. So we're not going to carry the intranasal version. That's really better suited to patients and family members who have a potential need for glucagon because of hypoglycemia. EMTs are now also permitted to use nebulized bronchodilators, so Duodeneb, albuterol, Atrovent. They can be administered for bronchospasm and allergic reactions. And because racemic epinephrine is considered by the FDA to be a bronchodilator, EMTs can administer nebulized racemic epinephrine for croup. So all these things have been added to the protocol. So everybody should be well aware of this, and if you're not comfortable administering these medications as an EMT, you should talk with your EMS coordinator to get appropriate training. I think it's also important to remind everybody that as an EMT, and all of us as providers, we have to understand the indications, contraindications of these medications, And we also have to know how to appropriately assess the patient before and after we use any of these medications. So IM glucagon can be a fairly easy task to learn, but you also have to understand the signs and symptoms of hypoglycemia. You have to understand how to use a glucometer. You have to understand that if you give IM glucagon, then you should recheck the blood sugar, 10 to 15 minutes later. And you should also have some understanding that glucagon isn't going to work well with people with cirrhosis. So it's probably not a great choice. But that's just kind of an example of, we all need to have an understanding of the indications and contraindications of the medications that we're permitted to use per the protocol. So I want to go to the allergic reaction, and I got the adult and peds here section because I talked about allergic reaction, and I really want to emphasize both in the adult version here that, and the pediatric version, which I'll show in a minute, that epinephrine should be given as soon as possible if the patient's having a true allergic reaction. And we have made adjustments so that if you have an acute allergic reaction, you can give up to 3 doses intramuscularly every 5 minutes. So that's for an EMT, advanced, or paramedic. You have a patient with acute allergic reaction, it's immediate epinephrine, either as an auto-injector or something you draw up. And every 5 minutes, the patient gets a dose until their symptoms improve. You can also provide duodeneb or bronchodilators for patients who are in bronchospasm, whether an EMT, advanced, or paramedic. And higher levels, advanced and paramedics can administer Benadryl, and paramedics can give dexamethasone. And if the patient is in trouble and you've given your 3 doses of epinephrine IM, you can use epinephrine as an epinephrine drip or push dose epinephrine to maintain patient stability during transport. So the things we've added is 3 doses of IM epinephrine, the fact that and that's at all levels of certification. Same thing with duodeneb, all levels of certification. And then epinephrine push dose or drip by a paramedic if the patient needs it for blood pressure control or for hypotension related to their allergic reaction. If you look at the pediatric side, it's very similar. It's the pediatric dosing is pretty straightforward, and it's weight based and it's a range. So if the patient is 7.5 to 15 kilos, they get 1 ml of 1 to 1,000. If it's 15 to 30 kilos, they get 0.15 mLs. And if it's patients over 30 kilograms, then they get 0.3 milligrams or 0.3 mLs IM. So same attitude. Multiple doses of epinephrine is needed to get the patient's symptoms under control. Unstable medical patients. So I talked about this at the March MEC Minute, and this is where I've mentioned in the past there's a dichotomy in how you're going to have to think. Unstable patients, we try to stabilize before we transport. Unstable trauma patients, it's some time-critical interventions and immediate transport. So our goal with the unstable medical patient is to stabilize before we transport. We want to correct hypoxia. We want to treat hypotension. And we do this to keep the patient from crashing in the truck. Studies have shown that if you have an unstable patient and you do not provide stabilizing treatment, they're high risk to crash while being transported. Here's our protocol, and it's pretty straightforward. We are not going to initiate transport of the patient if they're unstable, and if necessary, we're going to call for additional resources. The first thing we're going to look at is assessing the airway and addressing airway and issues in oxygenation. If the patient is having respiratory distress, which is the left column, we're going to give oxygen and consider CPAP or CPAP and BiPAP. If the patient's showing evidence of respiratory failure with poor respiratory effort, loss of muscle tone, their O2 sats under 90% despite oxygen administration, their mental status is altered, or their end-tidal CO2 is elevated, then we're going to start ventilation with a BVM, consider elevating the head, and if the patient doesn't improve, we're going to DSI them and get an airway secured. Our goal is to get their O2 sat over 94%. Once we have dealt with their respiratory issues, we're going to look at their blood pressure and Our goal really is to get the blood pressure over 90 systolic. And so if the patient has evidence of non-traumatic shock, meaning they're hypotensive without trauma, we're going to look for things like bradycardia, other causes of shock such as sepsis or cardiogenic shock, or we look for unstable tachycardia such as atrial fibrillation or VTAC. Either way, we're going to use our appropriate protocols to get them stabilized. If there's no improvement in these patients, despite our fluid bolus, whatever, we should consider push dose epinephrine or an epinephrine drip, again, with our goal systolic pressure of 90. Once we've reached that point, then we can think about transporting the patient. Now, I realize there's some patients you're going to start working on this, and no matter what you do, they're not stabilizing. At that point, you're going to need to decide, well, can I stick around a little bit longer to get the airway secured, or do you need to put them in the truck and start moving? That's why these are guidelines. Most of the patients will respond to our interventions on scene and be more stable during transport. If they're just in bad shape and not responding, then I think once we get the airway managed and fluids and or epinephrine started, we can start moving the patient. Unstable trauma patients or patients who are in traumatic arrest, our goal is life-saving interventions on the scene only. So we're going to control bleeding, relief and tension pneumo, and consider what type of ventilatory support do we need. Can you just bag them into the truck and you manage the airway after they start moving? I think that would be fine. But there, again, is where you have to use some clinical judgment. It might simply be slide an IGL in and start moving the patient. But either way, life-saving interventions, everything else in the truck. What does the algorithm look like? And this was out of a compendium article from American College of Surgeons and National Association of EMS Physicians. And it's kind of how do we assess the patients? So if they have evidence of a traumatic out-of-hospital cardiac arrest, do they have any injuries that are incompatible with life, such as decapitation, or evidence they've been down for a while, such as rigor or decomposition? Or do they have a DNR, in which case you would not resuscitate? But if they're a candidate for resuscitation, then we're going to perform life-saving interventions only on the scene, such as hemorrhage control, airway management, needle decompression, if indicated. And then we're going to institute treatment or transport, and everything else gets done in the truck. So if they're a candidate for TXA, if they're a candidate for ANSEF, if they need something else to be done, pain control, it's in the truck as you can do it based on your treatment priorities and the patient's condition. So the idea is to get these patients off scene so they get to a trauma facility as quickly as possible. If you don't have access to a trauma facility, then the idea is to get off scene so get them to a hospital where they can have stabilizing treatment and then secondary transfer. Pediatric DSI, question was asked about should we have one? Well, we do now. This is courtesy of Delaware County EMS. It's not as long as our adult version, but it's very similar. So, we want to position the patient correctly. We want to get everything set up that we need. We want to start the patient on high flow oxygen so they can have apneic oxygenation if necessary. And then we're going to intubate and provide via induction and paralysis. Patient may need atropine if they're bradycardic. Otherwise, we're going to use ketamine and rocuronium. And then once the tube is placed, we're going to give them fentanyl and midazolam, or we can give them ketamine. So this is pretty straightforward. Please take a look at it. If you have any questions, let me know. This was done at the suggestion of Dr. Kadish. Newborn resuscitation, I mentioned before, this is our version. It's pretty straightforward. It's based on the national standards. Children or babies when they're born, we look at them, get their APGARs, and, the questions are, is it term gestation or not? Premature babies have more problems. Do they have good muscle tone? Are they breathing and crying? So if they're not breathing and crying, we're going to warm, dry, and stimulate, which really you should do for all kids. They perk up a lot faster. So, get them in a blanket, get them a towel, warm them up, dry them off vigorously, stimulating them as you dry them. If they're apneic or gasping and their heart rate's less than 100, we're going to start bagging the patient. And if the bagging doesn't work, and their pulse rate drops under 60, we're going to start compressions. If compressions don't work, we're going to provide or use epinephrine every 3 to 5 minutes to again bring their blood pressure or get their pulse rate up and help them out. So pretty straightforward. It's not a lot different than what we've already been doing. It's maybe just formatted a little differently. Pediatric pulseless arrest change, just a relatively minor change made by Dr. Kadish, and it really has to do with when do we move the patients. You know, her preference is that pediatric arrest be moved off scene. However, look at the green box. Before we initiate transport, she would like us to obtain an advanced airway, probably an eye gel, although, oral airway and BVM might be a good substitute. Get an IV or an IO in and give the first dose of epinephrine into the child, and then you can think about moving the child or transporting the child. So that's the significant change via this protocol. Oh, the other thing I noticed is we made a correction. The first defibrillation is 2 joules per kilo, and then we go up to 4 joules. No change, a big one, epistaxis and post-tonsillectomy bleed. We've always had Afrin in there and recently added TXA, but we also get children who can have post-tonsillectomy bleeding, and it can be disastrous. Typically, when you have a tonsillectomy, scabs form over where the tonsils were, and those scabs can come off usually around 7 to 10 days post-op, and sometimes they can come off and there's an arterial bleed right underneath, and they can show up and have really bad hemorrhage. It can become life-threatening. So if you have a patient with post-tonsillectomy bleed, we can nebulize TXA and have via a regular nebulizer used for bronchodilators, and just nebulize at 10 milligrams per kilograms, and often it will shut the bleeding down. The maximum dose is 500 milligrams, so it's 100 milligrams per ml. Just figure out the dose and let the child breathe through the nebulizer. It will often stop it. Some other quick changes to review. Like I mentioned, TXA is now 2 grams IV push over 2 minutes, no more IV piggyback. TXA is now also indicated for children with the same indications as adults. The dosing is 15 milligrams per kilogram IV push up to 2 grams over 2 minutes. Because of some of our new members, such as M&M and Hawking, we're looking at a need to be able to redose patients with medications during transport, and they've had transport times that are such that they need more than 2 or 3 repeat doses. So essentially, we've for ketamine and fentanyl, we've removed the limit in terms of number of doses. The maximum dose or maximum milligrams per dose is the same, but now we can give it as many times as necessary to maintain patient comfort. Cardizem can be repeated 15 minutes after the first dose, but at half a dose if needed for tachycardia. The other thing I didn't mention on here is we've added that after 3 doses of duodenab, if the patient remains bronchospastic and there's a long transport time, we can administer albuterol only 2 or 3 vials in a nebulizer just to put the patient on a continuous nebulization. We've also added push-dose epinephrine for children with the same indications as adults. So basically hypertension, bradycardia, and it's basically if they're under, it's all weight-based. If they're under 10 kilos, it's 0.1 ml per kilo of the 1 to 10,000 up every 3 to 5 minutes. If they're 10 to 25 kilograms, it's 1 ml. If they're over 25 kilograms, it's 2 mLs IV push every 3 to 5 minutes. So it's still the same idea. Every 3 to 5 minutes, they get the medication. They get the same concentration. It's just under 10 kilos, they get up to 1 ml based on their weight. 10 to 25, they get 1 ml. Over 25, they get 2 mLs. We've also added to the procedure section that you can aspirate central lines before using them. Like I mentioned, we're going to allow termination resuscitation after 20 minutes, and you can still consider CPR time to other healthcare professionals in that 20-minute timeline, as long as on your arrival the quality of CPR is adequate. If they're in a bed with no backboard and there's a lot of recoil, I would not consider that an adequate performance of CPR, so you're going to have to work the patient for 20 minutes. But if the patient's got a good quality CPR, there's a backboard in place, they're ventilating the patient, yes, you can count that time. Based on some input from sports medicine, we've adjusted our heat exposure algorithm, and we've added immediate on-scene cooling for exertional heat stroke and added direction that EMS should work with on-site trainers and sports medicine providers. So I think we've talked about this before. We do a MEC minute on heat exposure. Someone who's exertional heat stroke, meaning a temp of over 104, 105, that is an immediate life-threatening event. They need to be cooled on scene, and their temperature needs to get down to about 102 before we start talking about moving them. So you need to work with the on-site medical staff in terms of how you're going to care for this patient. Question was asked if we can do Zofran IM, and yes, you can. So we added intramuscular as a route for Zofran. You can still use an IV or PO. Pediatric seizures, on the algorithm, we increased the maximum dose of midazolam to 10 milligrams regardless of how you administer it. So children, it's weight-based, but it maxes at 10 milligrams per route of administration. Previously, it was 6 milligrams. So we've pretty much been underdosing some of our children. Finally, two other changes that are kind of limited in their effect. Coshocton County joins us the first of the year. They have cardiologists who request that the patients receive oral Brilinta and IV heparin if they are suffering a STEMI. So we added Brilinta and heparin to the chest pain protocol, but it's limited to Coshocton County providers only. Similarly, Granville and St. Albans townships have manufacturer that does a lot of work with hydrogen fluoride, and they have an HF protocol, and the paramedics at Granville and St. Albans have received training about how to treat hydrogen fluoride exposure, and we've added a exposure algorithm protocol to our toxicology section. And for this particular treatment algorithm, the medications will be provided by the manufacturer. They're fairly specialized, such things as calcium gluconate paste, which is not expensive, but the manufacturer is going to provide it for us. So the crews have been trained. If at your location you're aware of other manufacturers that have hydrogen fluoride in their manufacturing process, we could train you up on how to treat that. We can also meet with the manufacturer if you think it's appropriate. Just let me know, and we can work that out. So that's it. Thank you very much. I really would like to thank Cody Smith at Truro for working with me on making the protocol edits. But I really want to hear your comments and questions, so please pass them on. I gave you my email address earlier in the talk. So thank you. Talk again next year.